right, good afternoon, everyone, and thank you for joining us for today's webinar focusing on key steps to restoring implants. My name is Adam, Content Marketing Specialist with Schein, and I'll be your moderator. If you have questions, please type them into the Q&A section of your control panel, and we will cover as many as we can live at the end of the webinar. Please make sure that your volume is up and any large applications are closed on your computer or mobile device to ensure a smooth connection. This webinar is presented by Henry Schein Dental, and no CE credits are being offered for viewing or attending this presentation. I am excited to welcome back Dr. David Wong. Dr. Wong is a board-certified periodontist and is a diplomat of the American Board of Periodontology, as well as a fellow in the International Congress of Oral Implantologists. Thank you for spending the hour with us, Dr. Wong. The floor is yours.
Adam, I appreciate the introduction and the invitation to return, so I really appreciate that opportunity. Today, we're going to switch it up a bit. Usually, I'm with you guys talking about surgery, which we're going to talk a little bit about some surgery today, but we're really going to talk about kind of the specialist restorative dentist dynamic and how we work together to restore dental implants. So we're going to go over a lot of strategies, some case reviews. You guys know my style. We're going to do a lot of case presentations just to kind of keep the learning a little bit more interesting. I know Zoom meetings are a little bit difficult sometimes to learn, so we're going to try to keep things moving. Real quick, a big thank you to Henry Schein Dental for the opportunity to speak once again. It's also a pleasure to be in a lineup amongst some esteemed colleagues and good friends of mine. Hope you guys will check out Dr. Knife Sonata's presentation, as well as Dr. P. Ray's presentation as well. Very excellent stuff. Matter of fact, they've done such a good job of covering some of the material that I was going to cover that I'm actually going to direct you guys towards their webinars. I'm going to do what I do best, which is a lot of single tooth implant dentistry. So a lot of you all know who I am, but if you want to stay in touch, have questions afterwards, feel free to chime in and message me on Instagram. I actually have two accounts. My main one is david.wong.dds, and the surgical account with all the surgeries and some of the photos that maybe you've seen before in this presentation. Maybe you have questions. Those are going to be on Plaque China. So message me there. So let's start off with a real quick, simple question. What's the problem? We're here for an hour, and which I appreciate y'all spending the time with me, but what's the problem? We're trying to solve a problem here. What is that problem? So let's look at a case that would typically show up in my office. And usually the way my office is set up, we get a referral from a restorative dentist, usually a general dentist. Sometimes they place their own implants, sometimes they don't, but this would be a typical type of a case where we have tooth number 8 that's failing due to internal resorption. It's a hopeless tooth. But on the other hand, when you look at this gentleman's smile, he's got a pretty good smile. He's got some older dental work that needs to be replaced. You can see the composite on to repair the fractured incisal edge on tooth number 8. So it's not a great looking tooth, but if you look at his overall smile, his teeth, they look pretty good. Matter of fact, it's a little bit of a challenge, a little bit of a daunting task, to replace this tooth and replace it with an implant. How do we go about doing that in a young gentleman that's perfectly healthy, great smile? So in this situation, and we'll talk a little bit about this in maybe future webinars, we chose to do a partial extraction therapy type of an extraction where we only took out the lingual portion of the root and the tooth and left the facial portion. This is a video from the Plaque China account that I was talking about. You guys may have seen this, but at any rate, this is how partial extraction therapy works. It's exactly how it sounds. It's partial extraction. So anyway, we chose to do that as a socket graft first, and then we're going to come back later on after 12 weeks. You can see that the socket is completely healed, and then we're going to come back in with a guided surgery, a guided flapless implant surgery. Here you can see we're inserting a BioHorizons tapered internal implant into the area of tooth number 8, and we're going to put a healing cap on it. There's other strategies that we're going to talk about here in a bit, but for this gentleman, we decided to go the staged approach. So at this point, I'm done and we're off after a healing period. Now we're off referring him back to the restorative dentist for the final restoration. Now here's the problem. This is where I usually lose all my cases. I don't have a whole lot of finished cases out there documented because this is usually where I don't see the patient anymore. So the patient goes away and he comes back and he calls me up and he says, look, I want you to take a look at this crown. So he comes back in, we take a picture of his smile, and then we take a picture with his lips back and everything. And you can see that the crown on number 8 is not something that he's happy with. It's not like what we talked about. I told him he would more than likely have a screw retained crown. He doesn't like the color and the shade. He doesn't like the way the gum tissue is contoured. He just doesn't really like the tooth. And so whenever I ask my colleagues, what do you think? And they usually come up with some of the same things as well. They don't really particularly like the tooth. And it's a shame on my end of it because we went through all this trouble to extract the tooth atraumatically. We grafted the socket, got a lot of bone. We were very kind to the soft tissues, trained the soft tissues pretty well. And then, the last thing I know, we have a nice straight, implant with a healing abutment. We come back and the patient's not happy. So who dropped the ball there and what can we do about it? So that's what we're going to be talking about today. So Henry Schein has come up with a few topics that they wanted me to address aside from what I would normally talk about. So I'll read those to you real quick. They want a restoratively-driven implant protocol that is guided by achieving an implant environment that is supportive of an aesthetically and functionally successful restoration. They want from me best practices related to healing, such as the length of the time to heal based on patient condition and the number of teeth extracted. They want me to talk about leveraging digital dentistry for careful case planning and interdisciplinary or doctor-lab communication. They want me to talk about the nuances of performing an intraoral scan on a patient with a healing abutment. I think they mean scan body, so that's what I went with. And then finally, we're going to talk about some digitally driven implant cases. So let's start off talking about healing. So I'm really interested in how specialists and restorative dentists interact. And I feel like in my office, we have a pretty similar protocol, but this is our worst nightmare, right? You have a patient that's referred back to your office from the periodontist or oral surgeon. They say the implant's ready to be restored. You go in there and try to take the healing cap off and you notice the whole thing moves, right? That's like the worst thing that could happen because not only is it awkward clinically because you don't know what to do at that point, but you also have to have an awkward conversation with your patient about why you're not making an impression that day and you're having to, start all the way over. So the first question that they came up with me for me to answer is, how do you know when an implant is healed, right? So here's a radiograph of a healed implant. It's got a healing abutment on it. It's the old BioHorizons external hex. So this radiograph is pretty old. But how do you know when an implant's healed? Has this ever happened to you? Where you get a radiograph, and I'm talking to you, restorative dentist. Have you ever gotten a case referred back to you, where the specialist says, okay, we placed implants for number 12, 13, and 14. We did a sinus graft, as you can see here. It's healed up, and now they're ready for the final restorations. Okay, so you go ahead and you make your final impressions. You send it off to the lab. The lab sends you back 3 crowns. You go to deliver them, and then boom, what happens? Number 12 go down great. Number 12 goes down great. Number 13 goes down great. But then you go down to torque down number 14 and the whole thing moves, right? So if it moves, obviously, it has to come out. So if this has ever happened to you, I'm talking to you, okay? If this has ever happened, know that you're not alone. It happens to all of us, but what happened, okay? And what can we do about it? So there's 4 different ways, there's probably more than this, but there's 4 basic ways that we check for osseointegration of an implant, okay? Number 1 is we just wait. We wait at the recommended allowable time, okay? Number 2, maybe we look and assess. We look at it radiographically or clinically. Maybe we tap on it, shake it, try to wiggle it, whatever. We're trying to just assess it clinically and radiographically. The third method, which is a proven method and well-studied, is the torque test, reverse torque test. And the fourth method, of course, which is the newer way, which is resonance frequency analysis. So those are the 4 ways. I'm going to review them because it's a little not as exciting as the other stuff we're going to talk about. So we'll kind of go through this. So the first strategy is just wait, right? So traditional healing times, if an implant's placed in the mandible, we generally allow 4 months of healing. If it's placed in the maxilla, we allow 6 months. Is that a good way to do it? It's an okay way. It's not very, scientific or anything like that. Not very evidence-based, really, because who knows the conditions of the bone and the loading conditions and the surgical placement, the healing of the patient, that type of thing. It doesn't take into account any of that stuff. It's just strictly 4 months for the mandible and 6 months for the maxilla. Second way is just look and assess radiographically and clinically. So radiographically, what we do is we take a good radiograph where we can see all the threads of the implant. They're not blurry or anything, but you look at the bone. You don't see any, periapical radiolucencies. You see a little bit of crestal bone loss, but nothing too crazy. You don't see, you see a good integration, if you will, where you see the threads in the bone. You don't see anything that looks like a periodontal ligament, so that's good. And then, of course, clinically, it looks pretty good, right? You have a healing abutment on. The soft tissues look pink and healthy and thick. There's no bleeding. There's no other signs of inflammation or edema, swelling, nothing, right? And then, of course, everybody grabs their mirror handle, and we always have to tap on it. And if it sounds like it's solid, then we go for it, right? Once again, are these good ways to determine whether or not an implant is ready for restoration? I don't know. It is what we do, though. So, but on the other end, every now and then you get an implant that you torque out, on delivery or upon, the final impression. So, the two proven ways, though, are the torque test and the resonance frequency analysis. Torque test evaluates a point in time. So if you really want to know if an implant's ready, you stick that torque, you get your torque wrench in there, you put it on 30 to 35, you reverse torque it. If the implant's solid, you restore it. Problem is if it isn't solid, then the implant moves and it fails. So it evaluates a point in time, not over time, and it's kind of a one and done, hit or miss type of a test. It is very cheap and very easy. And then, of course, I always remind people that implant stability does not always correlate to high insertion torque or to the seating torque whenever you're putting your implant in. So those of us who are doing a lot of immediate implants, immediate load and things like that, I always remind you, high insertion torque does not necessarily equate to implant stability. But what does? It's going to be our next thing. The resonance frequency analysis or the implant stability quotient, the ISQ. So what is that? So you guys may have seen this machine. I happen to use the one. It's Ostel. I get it for BioHorizons. You can buy it directly through Ostel as well. But it is also safe, easy to use. It does not harm the implant, unlike the reverse torque test, which, if you torque it out, you torque it out. This is nice and safe, easy to use, but you do have to buy the machine, right? Not only do you have to buy the machine, I'll show you here in a second, there's some pegs that you have to put into the implant to conduct your RFA to get your ISQ reading. So what ISQ does, it tracks the implant stability over time. So you can actually have a number, a hard and fast number. You know what to do with that number, and it helps you decide, how to act. So the downside is that this machine behaves a little bit differently depending on the implant design, the position, angulation, the depth of the implant, whether or not there's soft tissue, bunched up around the implant, and of course the operator, how you angle the probe. So how it works is it utilizes magnetic pulses upon a rod or a peg that's inserted into the implant to measure the resonance frequency. The higher the number, the more stable it is. The ISQ scale is on a scale of 1 to 100. So as an example, this gentleman right here that you're looking at, you can see that I've got the probe or the wand in my hand, and his implant tooth number 7. The reason that we're doing this is really helpful for us as dentists, because what happened with this guy is he's got a wedding that he's wanting to get to and have his tooth ready by. And it happened to be, in a couple weeks. So he's like, when can I get my tooth, right? When can I get my tooth? Patients are always wanting to know this. The beauty of an ISQ is that, for instance, we know that 70 and greater means it's got high stability. So with this gentleman, it's at 65, which is just medium stability. So it helps me to communicate to him that, hey, you know what, we need a 70 before I feel really good about, sending you back to your dentist to make the final crown. You're at 65 right now. That's good. It's not great. So it's up to you whether or not you want to move forward to get that tooth in time for your wedding. So what that does, it just gives us a number. That way it's no longer, well, it feels good, it sounds good. Now we actually have something quantifiable, something we can measure so that we can make clinical decisions. Anything less than 60, we call that low stability. And then if you really want more information, I would say look it up. But there's a whole nother presentation that we can do on RFA versus high insertion torque versus other things. So let's table some of this discussion for another day. So let's go with workflows, single tooth workflows. Once again, there are some full arch workflows, but there's just too many to do. So I'm going to let Dr. Sanada and Dr. Rossi do those in their webinars. So tune into their webinars. Single tooth workflows, why? So once again, this is a patient that comes from a restorative dentist. Good friend of mine sends over non-restorable tooth number 8. I send back eventually, we get the patient referred back to his office with a nicely healed implant. Here's the healing abutment. You can tell that the healing abutment's on. He's ready for the final restoration. So when he takes the healing cap off, you can see that there is no emergence profile because it was just a very narrow, straight profile healing abutment. So what happens here is we go ahead, and even if you have a scanner, great. If you want to go with the analog and the old style impressions, that's fine too. But in this situation, we stuck a scan body onto the implant, got our fancy scanner, scanned it in, and then of course we send it to the lab. The lab either uses a model, makes a model, or they don't. But at any rate, they make a crown, and here's what the crown looks like. So what happens in a situation like this? What happened there? You can see the tooth is big. The tissue is blanching. The patient hurts. Whenever we're trying to, put this implant in. To put the crown in. So we have to anesthetize the patient to put the crown on. Is that something that's acceptable? Is that right? Is there a better way? So let's talk a little bit about that synergy between surgery and the restorative part of it. So here we've got, and we're going to circle back to this case here in a second. Let's do this one real quick. So we have tooth number 10, completely hopeless, blown out facial and lingual plates, as you can see here from the CBCT. When you look at it just from this view, full blown out facial and lingual plates. Okay. So this is not a bone grafting talk, so I'll spare you all the details, but essentially we're cleaning out the defect. We're going to put some bone into the defect site. We're going to augment this site. We're going to cover our bone with a resorbable collagen membrane, and we're going to close it up. Okay. A couple of weeks later, we're going to take the stitches out. This is what it looks like from the occlusal view. And then 6 months later, we look at another CBCT to evaluate the bone. Looks great. So we go ahead with our implant surgery. Okay. So 6 months later, because of how much bone this gentleman had lost, that's why we're waiting 6 months. We open this guy up and we have all this bone, right? So we place our implant and everything's looking great. We let the implant heal up the appropriate amount of time. Once again, you can either use the torque test, you can use your ISQ, you can do whatever you want to do, but at any rate, we send the patient back to the dentist for the final restoration. As soon as the dentist gets the case back, he takes off the healing abutment, puts an impression coping on, like so. This is what it looks like for virtually every single implant company out there, right? You have a little post with a little knob, on the top of it. So impression post goes on. And as you can see, look at the soft tissue. Keep an eye on the emergence profile or the lack of when you look at these impression copings, because what happens is you can tell that things are not going to go good at delivery because, first of all, The lab had to make him a seating jig just so we could orient the final abutment so it wouldn't spin around. Okay, that's always a bad thing because it should fit pretty passively. We shouldn't have to mash it on. Second of all, as you're inserting your driver, through this seating jig into the abutment, you can see once again this is just the abutment. Okay, this is not even the crown, just the abutment. But you can see that the tissues are blanching like crazy, and once again the patient is hurting. Right, you can even see on the right side of the screen. Look at the tissues blanch on the palatal side. The patient is hurting. This is not something we want to do. It's not kind to the tissue. So as a periodontist, this is going to drive me crazy. So we had to make some minor modifications so that we could actually get this crown on like so. Same exact crown. Now it's a nice, beautiful restoration. Tissues are pink and healthy and not angry anymore. So this is really important. So going back to that other case, where the tissue's blanching upon delivery, what caused this? Now, what drives me crazy sometimes as the periodontist, and probably drives my oral surgery friends crazy as well, is that when this goes back to the lab because the patient isn't happy, usually the lab will say, well, it's the surgeon's fault, right? We didn't put the implant in the right position, or we put it in too deep, or something like that, right? That's always let's blame the surgeon, and rightly so, because we're also trained to just take responsibility for everything. So is it the implant position? I would argue that it's not the implant position. What's my argument for this presentation is, and we could talk for hours about this, is that it's poor tissue training with the healing abutment or the provisional restoration, whichever you choose. It's poor impression making, and it's a poor restorative design, quite frankly. So what do I mean by that? Let's not just throw it out there. Let's actually talk about this. So when we look at restorations, this is a courtesy. This slide is courtesy of my good friend, Dr. Heali Gluckman. If you look at the crown on the left, you can see how convex it is on the facial surface, right? That's pushing the tissues apically. It's causing that tissue to blanch. If you look at the correction on the same crown, you can see that it makes that S form, right? It's more concave at the cervix so that it doesn't press on the tissues. I borrowed another slide too from my very good friend, Dr. Curry Levitt out of Las Vegas, Nevada. He calls this the critical zone of contour. Look at his provisionals. So it has that nice little S-shaped curve, that nice concavity at the cervical portion on the facial half of the crown. But this is the critical zone of contour. So what we do is we focus on that critical zone of contour. We look at tissue training. We make better impressions, and voila, very, very simple. It's a very simple correction. All of a sudden, it's the same provisional, by the way. We can get it to look shorter. We can get it to look smaller, and it looks, not bad for a provisional at this point. But more importantly, it's kinder to the tissues. This goes right on very passively. Doesn't hurt the patient. So why do I care about all this? As a periodontist, I care very much, because if you look at some of the studies on some of these front teeth, we know that 80% of all sites, once you deliver the crown, 80% of sites get some facial recession within the first 3 months. And if you look at Tarnow's group, as a general rule, you get about 1 millimeter of recession on the facial aspect. Okay. If you look at Yuli Grunder's classic paper, also average recession on the facial surface of an implant is about 0.6 millimeters. So you're getting, implants alone are already getting 1 millimeter of recession. I really don't want over-contoured abutments and crowns to help me out in that area. Okay, so it's bad enough as it is. Let's not add to our problems. So let's talk a little bit more about over-contoured crowns. So here's another case that was referred to my office. Number 30 and 31, hopeless teeth. Number 30's got the big furcation involvement. 31's obviously non-restorable. So we take out those teeth, we do a basic socket graft, and then we come back in. Just like with a lot of patients, they don't want to replace the second molar, which is fine. So we replace the first molar. Okay. So healing cap's on. Now when it goes back to the dentist, the restorative dentist takes the healing cap off, and once again, you can see how small that emergence is coming from the implant. So what happens is when you take an impression of that, send it to the lab, in order for the lab to not, cause the tissue to blanch and have those complaints that we just talked about, with the tissue blanching and hurting the patient upon crown delivery, what they do now with an implant crown is this, right? And we've seen this before. We call this the old tomato on a stick. When you look at this radiographically, it looks kind of silly. In the mouth, it looks okay, but it looks kind of silly radiographically. But what happens with patients is that they'll complain about food getting stuck under there and their inability to clean under there very, very properly. So once again, this is not good. It's out there a lot. A matter of fact, you're going to see radiographs like this in virtually every dental office around the world. So once again, very, very minor modifications. You can see that it's not the implant position. The implant position puts us right in the middle of the central fossa. So I'm pretty happy with the implant position. It's all about the soft tissue here. So what we do is we get a wider healing abutment. So we don't always have to do everything customized, but in this situation, we just put a fatter healing abutment on for the patient. And then here we go, new crown. You can see that the new crown has more ideal and more natural contours, much more cleansable for the patient. Implant is still in great position. So the question for us is, this is the same exact implant, just two different restorations. Which would you prefer? The one on the left or the one on the right? Fortunately, we're slowly getting away from the tomato on a stick look. So the bottom line, the final restoration contours are impacted by implant position. Yes, that's true. But even just as much by the healing abutments or the impression copings and our impression making technique. So let's keep going with some of these single tooth workflows. Let's talk about immediate implants. A lot of times people, look at my cases and they're like, don't you ever do immediate implants? Do you always stage everything? I will say that I'm about half and half. Sometimes we do immediate implants, sometimes we don't. It really depends on what the patients present to us and what their needs and desires are, quite frankly. So here we are. Here's my neighbor down the street, literally, tooth number 9, hopeless tooth. All right. So what we've done here is we decided, based on a CBCT, once again, we can talk about this a different day. Long story short, we decided to place his implant immediately. This is what the tooth looks like from the facial aspect with it gone. I used his existing crown as the provisional. And that's not the lesson here, but it is a nice, cheap, easy way to do this. Just cut a hole in the lingual side of the crown, get yourself a temporary abutment. Here we're placing the implant as well as doing a little bit of soft tissue grafting. But long story short, we're using his existing crown as the implant provisional. So true to form, being with our friends, family, and neighbors, rather than wear this provisional for just a couple weeks before they go back to the restorative dentist, he actually wore his provisional for 3 years. Okay, so finally, I just told him, I was like, man, you've got to get your final restoration. So by this time, he didn't have a restorative dentist anymore. And he just came to me and says, why don't you make it? I said, you know what, I'll make it, but you're going to be a teaching study for me and for the dentists that I work with. So I'm going to show you with this on the same patient, same tooth, we're going to do the analog versus the digital workflow. So let's just say you get a patient like this from me or from your specialist, and you see that the implant's already been provisionalized. Okay, it's an implant system you're familiar with. Let's say you've already got all the right instrumentation. So analog wise, what do? Very, very simple. You take the provisional off, and you should see, you should see the implant, and then you should see a nice little sulcus like you see here. At this point, what you're going to want to do is put your impression coping on and take an impression. But here's the kicker. You can see on the right, as soon as you put that impression coping on, you count to 20, and you can see the tissue's already starting to shrink in around that impression coping. So one trick we're going to start off with, we're not going to end with this trick, but what we're going to start off with is we're just going to get some composite. and we're going to squirt it into the sulcus and around the impression coping, and then we're going to cure it. What that's going to do is prevent the soft tissues from collapsing in there. So essentially, what you've done here is you've made a chair side customized impression coping. You take an impression of this, okay? This should all look familiar to you, and then you pour it up or send it to the lab. They pour it up. In this situation, they've made a cemented restoration. So here we have the abutment, and there we have the crown on the model. Okay. Now, the reason that we take an impression that way is if you look at the model, okay, the model had that abutment comes off and on the model very, very passively. There's no squishing the tissue, okay, because the model is very accurate as to what we're seeing in the mouth. Now, here's just a side tip for you all. If you are stuck with the cemented restoration, make a silicone die. Okay, just get you some PVS material, squirt it into the crown, and just let it set. That's going to give you a little silicone die. And what you're going to do is put your cement into the crown, put it on this die first to get the excess off, and then put it on the abutment in the mouth. What that's going to do is just make your life a lot easier as far as cleaning cement, and you don't have to worry about jamming all the cement around the implant and that type of thing. So we don't have to worry about that. So here's the cemented restoration. Now, my neighbor, he got to enjoy the cemented restoration for about 7 minutes. And then we took it off because I reminded him, you're a teaching case now because we're doing this crown for you. So now we're going to do the same exact thing, except we're going to do it digitally. Okay, so digitally, remember, we're going to start here with the temporary crown in place on tooth number 9. So instead of, putting the impression post on and blah, 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 putting the customized impression coping in with the composite, we're going to do everything digitally. So we put the scan body on the implant. So here's our Plan Mecha Emerald scanner. Lots of scanners on the market. I happen to have the Plan Mecha Emerald. So here, what we're going to do, we got to do 2 scans. All right. So the first scan is the gingival mask scan, where you take a scan of the tooth with the provisional in place. Okay. Then what you're going to do is erase that part on the scan. That's what you see on the left side of the screen. That's why where the tooth number 9 is, it's a perfect circle. We've erased that. Okay. We've erased the provisional crown. Now we're going to put the scan body on the implant, and we're going to take a scan of that. So now you have 2 scans. You have your gingival mask scan, and you have a scan of the scan body. And now all you're going to do is you're going to stitch the 2 scans together, and voila, you have a nice, accurate model. Okay, this is kind of what it looks like. Here is your model. And now when you go to the mouth after the crown has been fabricated, this drops in as well because we've taken the time to customize either digitally or analog. We've taken the time to customize those impression copings and the scan body as well. So there's your final screw retained restoration. And this is the one that my neighbor gets to enjoy, hopefully for a lifetime. But I do want you to see the difference. Okay. In the case that I showed you before, when we put the scan body on, you can see that the tissues collapse around the scan body. So when the lab pours up the model or even makes a digital model, it's not accurate, right? But the crown is going to be anatomically made. So that's why the crown squashes and squishes, the gum tissue and makes the patient unhappy. On the right side, you can see that we've done it digitally, but we get a more accurate model. Okay. So when we take the time to train the tissues with either a customized healing abutment or a provisional restoration, we can get a nice, fast delivery of that final restoration, very quick, very painless. And it's just a better quality restoration. You can see what happens, when we don't take the time to do that. It gives us more to do later. Okay. So let's just get it right, give the patient a good experience and a quality product. So let's look at more immediate tooth replacement. So this gentleman, tooth number 9, we're just going to do the same exact thing, just so I can kind of reemphasize the digital workflow. Here's tooth number 9. We're going to take it out. He's got other problems as well, but we're going to do number 9, it's a long story why we're just doing number 9 right now. But number 9, we're going to take out. So anymore, we try to get a CBCT of everybody. We get our implant planned out. I don't like to do my immediate implants without a guide anymore. I just like a guide for that type of stuff. It makes me feel better. We used to do it freehand all the time, but now I like a guide, and I'll share with you why here in a bit. So here's our placement for tooth number 9. After we extract the tooth, we're going to utilize, once again, his old crown as the provisional. So here's the implant that's placed. What I like to do to attach the old crown, we just use either a metal or the plastic cylinders. This is a BioHorizons implant again. So we're putting the cylinder on top of the implant. The implant's got to be placed coming out of the cingulum, though. It's got to be lingually positioned. So that's what we have here. And then in this situation, I also use the IntraSpin, which is you also get that through BioHorizons. IntraSpin's nice for your PRF to help mix with your bone to make sticky bone. As you can see here, you can hold your instrument upside down. The bone just sticks to it. It's kind of nice. But at any rate, it's good for grafting. We're going to put our PRF membrane to kind of seal off the socket from the space between the provisional and the socket. We seal that off with our PRF membranes. And then here's your final CBCT. You can see plenty of bone to the facial of the implant and missing the nasopalatine canal as well, if that's important to you. And here we are. So one more thought about the analog workflow. I'm not trying to confuse you, but I'm just trying to give you more information. So I'm going to walk you through this analog style one more time, because I know not everybody has a digital scanner. So when we have tooth number 9, it's hopeless. Let's talk about this. So tooth number 9, you can see on the CBCT, the bone is going one direction, the tooth is going a different direction. So I chose not to do an immediate implant here, because if we take the tooth out, and if I pick the existing position of the position of the existing tooth, I'm going to perforate the facial plate. On the other hand, if I go the direction of the bone, okay, then we're doomed for a screw. I'm sorry, we're going to have to use an angled abutment and a cement retained crown. Well, this patient is a dentist. Okay, this patient is a dentist friend of mine. She's a really good referral, so I don't really want to do that to her. So what we ended up doing was we put her through ortho to improve the interproximal height of bone. Once again, a different talk for a different day. This is what the tooth looked like when we removed it. You can see that there's a facial fenestration. We're grafting the bone, put a membrane in, and all that stuff. We're going to close up. After 4 months, we went ahead and put the implant in. And once again, this is done with the guide and flaplessly. That way I didn't have to mess with the soft tissues. I waited about 4 months, and she actually made her own provisional restoration, which was nice. But at any rate, here's our starting point again. You have an implant, you have a provisional restoration on it. What do you do with that information at this point? So when you take the provisional off, this is what the sulcus looks like. Very pink, healthy, gorgeous looking tissues, right? You can see our grafting worked as well. Lots of thick, plump tissue to the facial of the implant. Everything's looking really, really good. So how do we keep it that way? How do we communicate that to the lab? I showed you a while ago how to do it with the digital scanner. And I also showed you how to customize your impression coping chair side. But the question is that the best way to do that? I don't personally like it that way. When I've got the time, and I always make the time, here's what I like to do. I'll take the provisional off of the implant. Okay, so this is what it looks like off. And what I'll do is I'll have my assistants pour up and set in stone a lab analog. So this analog is just jammed in some stone. Okay, I'll put the provisional on top of the analog, and then I'll take an impression of the cervical portion of that provisional. All right. And then after that sets, I'll take the provisional off of that and substitute it for the impression coping. Okay. Now, when that happens, I'll fill in the space between the impression coping and the impression of the provisional restoration. I'll fill it in with flowable composite, just like so. And then we'll light cure it and pull it off. And here you have a nice customized impression coping. I like fabricating it indirectly like this because, number one, it doesn't take very much time, but it looks a whole lot better and it's way more accurate. So here's the indirect version on the left. Here's a direct impression coping that we did chair side on the right. You can see it looks so much better and nicer when you do it indirectly. So here we are. Your impression coping goes into the mouth. Take an impression just like so. You're going to stick that back into the impression. Here's your nice, accurate master cast so that whenever you deliver the final restoration, this is the date of delivery, it plops right in very passively, nice and perfect. Okay, and there we are. Now, once again, we did all of this, went through all this trouble because of the way her upper alveolar process was shaped. And here we have the implant. You can see, once again, it misses the nasopalatine canal there and the incisal canal, and then you have plenty of bone to the facial aspect of the implant. So this is more restoratively driven dentistry. So how do we manage a failed site? So there's a lot of unique situations that come up in our field, and this one comes up. So we have tooth number 9 sent over from an oral surgery colleague of mine. He says, "Look, I've done 1,000 implants. This happened to me. I'm not a periodontist. This is kind of more your thing." So this is what we did. So we have tooth number 9 here. You can see the implants had to go. We went ahead and put a free gingival graft on at the time of the explantation. This is what it looks like all healed up. Implant's now gone. We're going to come back in and we'll do a bone grafting course, I'm sure. I've got to do 5 more webinars with Henry Schein. So put in your requests and I'll get all your questions answered. But at any rate, we're going to perform a ridge augmentation here, once again using the PRF, from the Interspin machine. We're going to get some bone scrapings. So we're using some autogenous bone. Here's our sticky bone. I'm going to place it on the ridge, wrap it all up in a nice membrane here, and close. Okay. Now in this situation, we're going to let that heal up 6 months again because it's a pretty big defect. So here's our surgical guide planning. This is with Bio Horizons once again. So implants in place. You can see the proposed implant position, mostly in the center of your screen here. We have the provisional already kind of sketched out as well. So the implant goes in. Long story short here, I miscommunicated with the lab. Provisional was not ready. So I went ahead and put a scan body on the implant at the time of the implant. Went ahead and closed up. So instead of uncovering the implant and putting a healing abutment on it later, I uncovered the implant, and I had Vulcan, which is my lab for anything related to implants nowadays. They made a provisional for me, so I don't have to do it because I have, just like you all, I'm a periodontist, so I don't do this all day long. They do this for relatively inexpensive cost here. So you can see the provisionals is made with the critical zone of contour in mind, so that we just screw this thing in whenever we uncover the implant, and this is how he's going to heal. The reason he's going to heal like this in a provisional is because he's got other dental work that he's going to do. So we're going to get everything all restored at the same time. If you don't want to do provisional, so let's say a patient has money issues financially wise, or maybe they just through miscommunication with your restorative dentist, they just spent all this money on a flipper, right? And they don't want to just not use it, or the dentist might get mad at you because you're going to deliver a provisional, and now they've essentially charged the patient for something they don't need. So a lot of times patients still want to keep the flipper, and that's fine. So here we have tooth number 8. That's obviously hopeless as well. So once again, we went through with the Bio Horizon surgical planning. Vulcan Labs makes the guide, and Implant's going to go in, but instead of making a provisional so the patient can still wear the Essex retainer or flipper or whatever they want to do, rather than do all that, rather than make a provisional, we go ahead and make a custom healing abutment. And you don't have to do this. You just tell the Vulcan lab to do this. They'll make the custom healing abutment, and they can make it out of PMMA. They can make it out of titanium, like they've done here. So this is what I like. It's metal. It's nice and kind to the tissues, but you can see it keeps and holds the tissue architecture perfectly. And you can do this and leave it for as long as you want till the patient's ready for the final restoration. And at this point, if this shows up in your office, hopefully you know exactly what to do from this point forward. Customizing the challenging case. So some of these surgical cases get kind of crazy. Not everything's ideal. And I'm going to try to wrap things up a little early so we can do some question and answer. But here we've got tooth number 9 and 10. Patient has no clue outside of the fistulous tract there that the teeth are even hopeless at all, right? So the teeth have to come out, and it leaves a gigantic defect. And I was trying to be a little heroic in my efforts, and we went ahead and did a bone graft and ridge augmentation, got the membranes going, got the PRF membranes going, did everything that I knew to do at the same time to try to get the patient moving as quickly through this miserable process as we could. The problem is that, just a short, 2 to 3 weeks later, we have her come in for a radiograph because she's reporting that she's getting pus coming out of the gum tissue. So we take a radiograph and we notice that, unfortunately, the majority of her graft has failed. This is what she looks like 6 months post-op. Just does not look good. Okay, things are not looking good at all. So we go back in and we're attempting to regraft, and you can see that we have a gigantic vertical defect, to say the least, in the area of number 9 and number 10. Number 11 is not even looking that hot, but at any rate, we're using a technique that's described by my good friend here, Bach Lee, using the tenting screws to rebuild the bone. You can see how much bone loss we have here. Then we're once again going with the bone graft, membranes, and we're going to close up. Now, fortunately, this time around, we do have a successful procedure. You can see from our CBCT, got a whole lot of width, bone growth almost to the head of the screws, which is great. After looking at some of Bach's research, I felt a lot better about myself, because even in the research, it looks like a good percentage of people do have to go through, when they have defects that big, they do have to go through multiple surgeries a lot of times. So I didn't feel too bad. But here's the problem. Once we put our implant in, so you can see pre and post graft how much bone we were able to grow. Look at the bone growth relative to the heads of the implant, the heads of the tenting screws. Implant's going to go in. We chose to just implant number 9 actually instead of number 9 and 10. So we're going to just cantilever number 10 off of number 9. But see how deep the implant's going to have to go. This is a BioHorizons tapered internal implant as well. So you can see how deep the implant is. So how are we going to? Nobody makes a healing abutment that's 8 millimeters tall. That's got to be custom. On the other hand, if you do it custom chair side, it's not going to look that great, and you're going to have all this roughness underneath the tissue. So it's easiest whenever you do your surgical guide planning, with Vulcan, just to have them make a titanium healing abutment. And that's what we've done here. So the implant's in place, it's in a good position, and we just put the titanium healing abutment on, and then send her back to the restorative dentist. He can then make customized impression copings, just like I showed you earlier, and there you go. Okay, this is just her provisional, but you can see even with her provisional, she can smile as big as she wants to. Nobody can really tell all the stuff that's going on in that number 9 and 10 area. Restoring multiple adjacent implants is not any different. So if we look at these situations going from left to right, you can see that we have custom healing abutments, custom healing caps, whatever you want to call it, to our custom impression copings. And then here we have the screw retained restorations and then the delivery. So we look at this case here. This gentleman he was got a hopeless bridge from number 28 to 30. 31 also was extracted as well. There's the occlusal view of those restorations. Here we've taken the teeth out, we've grafted. What you're seeing at this point here is at the time of the implant placement, and then here's the time of the implant uncovering. So we did a 2-stage approach here, really slow played this case. But at any rate, what you want to get used to on these types of cases where you have implants at different levels and things like that, what I like to do for my restorative dentist is I'll uncover the implants and I will make the custom healing abutments. I like to do it. Sometimes they like to do it. So it's a communication thing. But if you're going to do it, just grab you a temporary abutment. Once again, they come in either plastic or metal. I generally like the metal ones, but this is just showing you how to do it on a plastic one. Just grab the cylinder, do just a general buildup with composite, and then just cut down the cylinder to the appropriate height. Polish up your custom healing abutment and screw them on. So whenever you do your uncovering, you just screw these guys on, and then you'll see how quick it heals in 2 weeks. You have nice, beautiful, soft tissues, and then just go with your impression copings, and then here's your final screw retained restorations here. Okay. From the facial aspect, that's something else that we can talk about later on is the soft tissue healing on the facial. You can see we have plenty of keratinized and attached gingiva despite all the bone grafting and things like that. So let's wrap this thing up. We've got about 9 minutes here. Let's go back to this case. So remember, this is a gentleman that was referred to me for hopeless tooth number 8 due to internal resorption. And we went ahead and took him through the partial extraction therapy where we left the facial part of the tooth. And I sent the patient back to his dentist looking like this, basically with the implant and the healing abutment on. We didn't have a whole lot of communication, so I wasn't aware that the dentist didn't know what to do next. The assumption was from him you take the healing abutment off, you put an impression coping on, you take an impression, send it to the lab, and they make it. The problem is if you only do that and leave everything up to the lab, this is something typical of what you would get sometimes, right? Shades off, contours are off, it's cemented instead of screw retained. So the patient's just not happy. Okay, and I asked you guys what you thought. I'm sure we're all on the same page here. So what we did after the modification, what we did here is just, instead of using that as the final restoration, we use that as the provisional restoration. So we go through and we make the custom impression copings, make a more accurate impression, communicate with the lab a little bit better. And we pay attention to that critical zone of contour, which is something that you may have to educate your lab about because they may not know that, right? Because natural teeth don't have that critical zone of contour like implants do, okay? So this is our new final restoration for now. Patient's a lot happier. This is where we started. This is where we ended up. And here's our radiograph. You can see plenty of good bone up around this BioHorizons Taper Pro implant. Bottom line, develop a workflow for various situations and be sure to communicate with your specialist or your restorative dentist. We need as much information as possible at the beginning. This is really important because a lot of times, patients will come in with a hopeless tooth and somebody will just take the tooth out, right, without even thinking about what the next steps are. We need to talk about who's placing the implant and who is telling that person where to put the implant. We need to talk about the healing approach, whether or not we're doing it immediate or delayed, or is the surgeon putting a cover screw on or a healing abutment or a custom healing abutment? Are they going to eventually give you a provisional? Who's making the custom impression coping? So who's doing any and all of these steps? And it's really important to know this, right? Because these steps, as I've shown you today, are very critical in getting a nice final restoration for the patient. And if you don't know how to do it, ask questions, learn how to do it. I don't think in the last 54 minutes that I've been talking that I've shown you anything that you can't do on the restorative aspect. Very, very minor details. Finally, we need to make an accurate impression of properly trained tissues and communicate with the lab as to what you want. Okay, so starting from the top to the bottom. If your specialist gives you a narrow healing abutment like this, that's a no, right? You got it. You can't just take an impression of that, because what will happen is you'll get the tomato on a stick. The picture beneath that, you have a healing abutment. That's a maybe. Depending on the size of the tooth, that could work out pretty well for you. Maybe it does, maybe it doesn't. But the ideal way would be to make a custom healing abutment that is the perfect size and shape as the tooth that you're replacing. So in this situation, the second premolar. And you can see as soon as we take that custom healer off, look at that soft tissue. Now that's going to be perfect for a nice final impression and a nice restoration. So with that, with 4 minutes to spare, reminder, if you guys want to keep in touch with me, hit me up on one of either of these two Instagram accounts, david.wong.dds or Plaque China. And ladies and gentlemen, that's my time. Thank you very much. And Adam, turning it back over to you for some Q&A.
All right. Well, Dr. Wong, thank you so much. And as I expected, we have a lot of questions. So let's see how many we can get through. All right. So the first question was, what is the criteria of engaging and non-engaging abutment on 3 to 4 units bridge?
Okay. So that's a pretty common question too. And I would say non-engaging is always nice, especially if the implants are kind of offset, because you don't have to worry too much about things that are, you don't have to worry about the orientation of everything, right? It's just non-engaging. So what that means is that your abutments fit over the whole hex or whatever the attachment is. For single tooth, obviously you're doing engaging. For 2 teeth, I would still say you're doing engaging. I would say when it comes to 3 teeth, if they're parallel, there's no reason to do anything but engaging. Where non-engaging comes into play, whenever I've worked with my restorative dentists, is where you don't have perfect angulation, and you have to do non-engaging. So it's more of like a telescoping type attachment over the non-engaged implant. So I would say, to answer to your question, would be depending on your angulation and position of the implants. Generally speaking, you're always going to go engaging unless your angle's off on 1 or more implants, and you got to go non-engaging.
What do you do when the implant comes off, like the case you showed? Do you graft and wait or reinsert another bigger implant?
Yeah. So if the implant is just a lack of integration, it just comes out. Okay. So what I do, the implant comes out, everybody's got to, change their diaper for a second there. But when you figure it out, when you settle down and you start thinking about it, what I do is I get a probe. I try to feel around in the osteotomy side. If I feel, there's plenty of bone, and we're not already at the maximum implant size, we can put a bigger implant in, we will. But I would say more often than not, something's happened. There's like an infection or something like that. Maybe we never cleaned it out as good as we thought we did, and there's something still in that osteotomy or previous socket. And that situation, I'll just regraft and wait to fight another day.
What bone material did you use for the lateral incisor case?
For the lateral incisor case, well, almost always we're using mineralized on that, and then we'll mix it with the PRF if we can. So mineralized, it comes from BioHorizons.
Would a wider implant with a larger emergence profile healing cap have corrected the emergence in the molar case that you shared?
So molars are interesting, right? Because almost always your molars are going to be, in the 4.8 to 5.5 millimeter diameter range. So the diameter of the implant isn't so much as important as the diameter of the healing abutment. Healing abutment's a more important thing. The problem is that not all implant companies make wide healing abutments, so you end up having to customize it yourself.
Do you standardize the size of healing abutments you use per tooth type? For example, a particular size for molars, premolars, etc., or is it always case dependent?
For me, it's always case dependent. And the reason that is because, molars, as an example, I mean, they can range in size. And as far as the space goes, sometimes you'll have, mesial inclination of the second molar if the first molar has been missing for a long time. Or sometimes, it just depends on the size of the mesial. I base it on the mesial distal length of the edentulous ridge is how I base mine. So it depends on the case.
Why can't we do some gingivoplasty prior to seating the crown within the seating area of the implant to relieve the tissue impingement?
Yeah, so that's a common way to do it. Matter of fact, that's what gets you in trouble in the first place, because that's exactly what the lab does on the bench top is they actually do the gingivoplasty because they can't see your model. So they actually do the gingivoplasty so that they can make the crown and the abutment fit on the model. They don't tell you that. So that's why it ends up, that's why the tissue ends up blanching. You could do that. The problem there is you have a lot of blood, and it's just not, you have a lot of blood. It's not going to be the most accurate. And I will say I've done this before. What we end up doing is we use an indelible pencil and we mark the soft tissue. And that way we know exactly where to reduce, and we kind of have to, eyeball how much to reduce. So the answer to your question is if it's screw retained, you could probably get away with that. But the patient's not going to be very happy. And there's just a lot better, more atraumatic ways, uninvasive ways to do that.
If you have a through and through bony defect with labial and palatal bone, both perforated, do you place a membrane over both the labial and palatal areas?
You are obliged to place a membrane over the facial and the palatal areas. The case that I showed, you'll notice that I forgot to do that on the palatal area and the bone caved in. So that is something that we do talk about in the bone grafting talk. But yes, the answer to your question is yes. You put a membrane anywhere there's a perforation.
For the internal connection of the implant on the aesthetic zone, which do you recommend, an internal hexagonal or conic shape connection?
Generally speaking, a conical connection is more stable. And I say generally speaking, conical connections don't necessarily mean more stability, but generally they do. Especially if it's a long conical connection, because the length of it, you get a little bit more stability. The reason that's better typically is it's more stable, so it's not going to come as loose. Also, it tends to be a tighter fit, so bacteria doesn't get in there.
All right, and I know we're a little over on time, but we've got a few questions left.
Yeah,
that I'd like
fire away.
Is the Vulcan custom abutment made from an impression take prior, or is it just based on the tooth number?
Okay, so it's based on the CBCT. So whenever you send in your CBCT and your models, okay, so how it works is you either send in an actual model or a scan of a model or a digital scan, either way. And they digitize it and they overlay the model with your CBCT, and that's how they know, the size and the shape of the tooth. So it's that's how they do it, based off the models that each send.
Is a torque test only for screw retained implants?
No, the torque test is for any implant. Yeah, any implant.
Can you explain timing after placement for use of ostel?
The ostel?
Yeah.
So you can do it anytime. You can do it at the time of implant placement. If you're thinking about, immediately, putting a provisional on and loading it even. You can do it a month after. You can do it at any point. And matter of fact, that's what it's designed to do, is to show you the increase in stability over time. That's the whole purpose of it.
Any evidence for survival of implants based on ISQ?
There is lots of evidence, actually. I would say the best thing to do would be to get on their website. There's a lot of literature on that. And it's not just social media people talking about it. It's actually very, very, very nice studies on that. But there's lots. Like I don't want to say thousands. There's not thousands, but I would say it's probably in the hundreds as far as the resonance frequency analysis, or ISQ.
And last question, can you quickly explain or re-explain the torque test?
Yeah, the torque test. So a couple different ways to do it. But the reverse torque test is what most people refer to. So, whenever you put your implant in, you have your driver, right? So you can hand socket it in or hand ratchet it in. So all you do is you stick your driver into the implant, reverse torque it to from 30 to 35 Newton centimeters. Doesn't move, you're good to go. Problem is if it does move, then you messed up. So it's not good to go. And not only is it not good to go, unlike the ISQ test where you just wait a little bit longer, you actually just ruin the whole thing because you reverse torqued it and it moved. So that's why it's an all or none type of test. But that's a very common one that they've used and promoted in the past. I wouldn't recommend doing that as your go-to.
All right. Well, that'll do it for us tonight. I recommend everyone go follow Dr. Wong on Instagram. And I believe you did mention the Dr. Sonata and Dr. Payray webinars. We will send those out to everyone in the post-webinar email with a copy of today's presentation. So stay tuned for that. I would like to thank you, Dr. Wong, for your presentation. And of course, thank everyone for attending.
Thank you, guys. Really appreciate the opportunity once again. We'll see you guys soon.
All right. Thank you. Stay safe, everyone.
All right. You too.